Hello and welcome to the Irish Practice Nurses Association online educational series for general practice nurses. My name is Teresa Lowry-Lenin. I'm a member of the Carlow branch of the IPNA, and today we're going to talk about gastro-oesophageal reflux disease. Gastro-oesophageal reflux disease, more commonly known as GORD, is a common disorder of the gastrointestinal system. A higher incidence occurs in people living in Western countries, and it can affect up to 20% of the general population. GORD is defined as symptoms or complications resulting from the reflux of gastric contents into the esophagus or beyond into the oral cavity, which includes the larynx or lungs. The most common cause is defective functioning of the lower esophageal sphincter, leading to excessive acid exposure in the lower esophagus. In healthy people, the angle of His, where the esophagus enters the stomach, creates a valve that prevents bile, digestive enzymes, and stomach acid from traveling back into the esophagus, which can cause burning and inflammation of sensitive esophageal tissue. Most patients with GORD present with the classic symptoms of heartburn and acid regurgitation, reporting a burning feeling in the retrosternal area, rising up into the chest and radiating towards the neck, throat, and occasionally the back. Up to 40% of patients with heartburn will have a diagnosis of GORD. Symptoms occur particularly after ingestion of fatty, spicy, and citrus products and alcohol. The columnar epithelial lining of the esophagus cannot withstand acid, and this leads to inflammation. Other symptoms include vomiting, halitosis, anorexia, dysphagia, cough, and respiratory or oropharyngeal symptoms. GORD may be just an occasional symptom for some people, but for others it can be a severe and lifelong condition. Left untreated, it can cause considerable discomfort and a poor quality of life. Medical attention should be sought and symptoms investigated when GORD is severe, occurs several times a week, over-the-counter medication is not helping, dysphagia or other symptoms such as vomiting, hematemesis, anemia, or unexplained weight loss occur that could suggest a more serious problem. Risk factors include first-degree relatives of patients with GORD are actually 4 times more likely to develop symptoms, raising the possibility of a strong genetic contribution to the etiology. Medicines like calcium channel blockers, nitrates, and non-steroidal anti-inflammatory drugs can cause GORD or make the symptoms worse. Risk factors for complications include advanced age, obesity, alcohol, and tobacco use. There's no clear association between gender and esophageal stricture. However, men are at greater risk of developing erosive esophagitis, Barrett's esophagus, and esophageal adenocarcinoma than women are. The presence of a hiatus hernia increases the likelihood of GORD due to mechanical and motility factors. There's a substantial overlap between symptoms of GORD and those of eosinophilic esophagitis, functional dyspepsia, and gastroparesis, posing a challenge for patient management. Coexistent dysphagia is considered an alarm symptom, and that requires investigation and evaluation. GORD may lead to Barrett's esophagus, which in turn is a precursor condition for esophageal cancer. The risk of progression from Barrett's to dysplasia is estimated at approximately 20% of cases. Esophageal cancer typically affects people aged between 60 and 80 years, with the most important risk factors being severe long-standing GORD, smoking, and heavy alcohol consumption. A presumptive diagnosis of GORD can be made based on the typical symptoms of heartburn and acid regurgitation. Heartburn is described as a burning, retrosternal, rising sensation associated with meals, although this definition is often poorly understood. As practitioners, we need to be aware of this and clarify the nature of the symptoms being discussed when the term heartburn is used by patients. Diagnostic tests for GORD include endoscopy, a barium swallow or meal, manometry, 24-hour pH monitoring, and blood tests, mainly a full blood count, which should be taken to assess for anemia, which could be a sign of internal bleeding. As you can see by the chart on the left, there are advantages and disadvantages to the different diagnostic tests performed for diagnosing GORD. For example, with endoscopy with biopsy, a disadvantage is that it's invasive and requires sedation or general anesthesia. GORD can be classified according to the presence or absence of erosions on endoscopic examination. Absence of erosions are classified as non-erosive, known as NERD, whereas GORD symptoms with erosions is classified as erosive esophagitis. The primary role of endoscopy is to look for complications and to exclude other diagnoses. Endoscopy is recommended for patients who are at higher risk of Barrett's esophagus, a precursor for developing adenocarcinoma, which is more common in male patients over the age of 50. Manometry is used to assess how well muscles at the distal end of the esophagus are functioning. A tube containing pressure sensors can measure the pressure in the esophagus and help determine whether surgery may be necessary. A barium swallow or meal may be required to assess swallowing ability and look for any blockages or abnormalities in the esophagus. 24-hour pH monitoring may be necessary to measure the acidity levels in the esophagus and confirm a diagnosis of GORD. It is the gold standard and most objective test to diagnose the reflux disease. A urea breath test is recommended as a non-invasive test for active H. pylori infection, but this does not confirm or establish a diagnosis of GORD. Improvement following short-term treatments with proton pump inhibitors does suggest a positive diagnosis. Short-term treatment with proton pump inhibitors may help predict abnormal 24-hour pH monitoring results among patients with symptoms suggestive of GORD. So here's a chart just showing if the red flags are present, yes, then the patient would be referred for endoscopy. If not, is it heartburn with or without dyspepsia? If yes, start a PPI and then step down. If it's not, is it undifferentiated dyspepsia? If yes, empirical treatment with a PPI or consider testing and treating for H. pylori. And if not, functional dyspepsia investigated but no cause is found. If the answer is yes, then commence a trial of PPI. Other causes of chest pain, such as heart disease, should always be outruled before making the diagnosis of GORD. For instance, laryngopharyngeal reflux, often shortened to LPR, or extraesophageal reflux disease, is another kind of acid reflux which causes respiratory and laryngeal symptoms. Unlike GORD, LPR rarely produces heartburn and is sometimes called the silent reflux. LPR causes symptoms like sore throat, chronic cough, hoarseness, voice changes, difficulty swallowing, tooth decay, asthma, postnasal drip, and it is when stomach contents reflux beyond the valve at the top of the esophagus, and that's called the upper esophageal sphincter, into the back of the throat and airways. So let's look at the treatment and management of GORD. The management of GORD includes pharmacotherapy, dietary and lifestyle changes, and in some cases it may require surgery. The initial treatment is guided by the severity of symptoms, and treatment is adjusted according to the response. The extent of healing depends on the severity of the disease, the treatments chosen, and the duration of therapy. The patient should be advised about lifestyle changes, about avoiding excess alcohol and consumption of aggravating foods such as fats. Other measures include smoking cessation and weight reduction if it's applicable, encouraging the patient to raise the head of the bed when they're sleeping, and the avoidance of wearing tight-fitting clothing and bending down after a meal. Initial management for mild symptoms may include the use of antacids and alginates, which reduce reflux and protect the esophageal mucosa. Histamine H2 receptor antagonists, such as ranitidine, may be used to relieve symptoms and allow a reduction in antacid consumption. For more severe symptoms in patients with esophagitis, esophageal ulceration, esophageal reflux, and Barrett's esophagus, treatment involves the use of proton pump inhibitors, better known as PPIs. There are a wide range of PPIs available, including omeprazole, pantoprazole, lansoprazole, and esomeprazole. Esomeprazole is the S-isomer of omeprazole, has been found to show more improvements than any of the other PPIs. So this diagram just shows us how PPIs turn off proton pumps and reduce acid. Current studies have shown that the treatment of reflux esophagitis with esomeprazole is more cost-effective than treatment using any other PPI, providing a greater healing rate at a lower cost. Patients should take their PPI medication first thing in the morning before food. If a morning dose is not sufficient to control their symptoms, a second dose may be required in the evening. If symptoms persist after 4 to 6 weeks of treatment with a proton pump inhibitor, the patient will need to be reassessed. When symptoms resolve or abate with PPIs, the treatment can be titrated down to a level which retains remission. This involves either reducing the dose, giving it intermittently, or substituting it with a histamine H2 receptor antagonist. However, for endoscopically confirmed erosive or stritchering disease or Barrett's esophagus, treatment with a PPI usually needs to be maintained at the minimum effective doses. Non-response to PPIs may suggest an alternative diagnosis such as peptic ulcer disease, upper gastrointestinal malignancy, functional dyspepsia, eosinophilic esophagitis, or achalasia. So here we'll talk about treatment and management in pregnant women and in small children. So if GORD is unresponsive to diet and lifestyle changes in pregnant women, antacids or alginates may be used. If this is ineffective, ranitidine, a H2 receptor antagonist, might be used. Omeprazole is reserved for pregnant women with severe or complicated reflux disease. GORD is common in infancy, but most symptoms resolve without treatment between 12 and 18 months. Mild to moderate reflux without complications in infants can usually be managed by changing the frequency and volume of feed or by providing a thickened formula feed if advised by a dietitian. If necessary, suitable alginate preparations can be used instead of thickened feeds. For older children, lifestyle changes may be helpful, followed if necessary by an alginate-containing preparation. Infants or children who do not respond to these measures or who have complications such as esophagitis or a respiratory disorder need to be referred to hospital as a H2 receptor antagonist may be required to reduce acid secretion. Omeprazole, a proton pump inhibitor, may be required if the esophagitis is resistant to the H2 receptor blockade. Antacids containing aluminium or magnesium compounds can often relieve symptoms in ulcer dyspepsia and non-erosive GORD. Antacids are best given when symptoms occur or are expected, usually between meals and at bedtime. Conventional doses of liquid magnesium aluminium antacids, 3 to 4 times daily, promote ulcer healing but are not as effective as anti-secretory medication. Magnesium-containing antacids tend to be laxative, while aluminium-containing antacids tend to be constipating. Antacids containing both magnesium and aluminium can reduce colonic side effects. Sodium bicarbonate should no longer be prescribed alone for the relief of dyspepsia, but is present as an ingredient in many indigestion remedies. Bismuth-containing antacids are not recommended, as bismuth can be neurotoxic. Calcium-containing antacids can induce rebound acid secretion, and prolonged high doses can cause hypercalcemia and alkalosis. Simethicone, added to an antacid, is an anti-foaming agent to relieve flatulence and can be useful for the relief of hiccups in palliative care. Antacids should not be taken at the same time as other medications, as they may impair absorption and damage the enteric coating of other medications. Caution must always be maintained with the use of H2 receptor antagonists and proton pump inhibitors, as they can mask the symptoms of gastric cancer. Particular care is required in patients presenting with alarm features. In such cases, malignancy should be outruled before treatment commences. Side effects of H2 receptor antagonists include diarrhea, headache, dizziness, and the H2 receptor antagonist cimetidine should be avoided in patients stabilized on warfarin, phenytoin, and theophylline. Side effects of PPIs include gastrointestinal disturbances, dizziness, headache, and sleep disturbances. Patients at risk of osteoporosis on PPIs should maintain an adequate intake of calcium and vitamin D, and if necessary, receive other preventative therapy. Long-term use of PPIs has been linked to complications such as vitamin and mineral malabsorption, pernicious anemia, gastrointestinal infections, gastric cancer, and dementia. Surgical treatment for severe GORD recommended only for those who do not improve with PPIs includes Nissen fundoplication, Link's magnetic sphincter augmentation, Transvaal incisionless fundoplication. The Nissen fundoplication procedure, seen here in the top upper right diagram, involves the upper part of the stomach being wrapped around the lower esophageal sphincter to strengthen the sphincter, prevent acid reflux, and to repair a hiatal hernia. Uncertainty surrounds the benefits of surgery versus long-term medical management with proton pump inhibitors, and GORD patients with no response to PPIs are less likely to do better after surgery. The lower diagram shows a diagram of the Link's magnetic sphincter augmentation procedure. Gastro-oesophageal reflux disease is a common disorder and is one of the most frequent conditions encountered in primary care. Treatment and management of GORD symptoms is important, and early intervention has the potential to reduce serious complications. The goal of effective treatment is to effectively control symptoms, prevent complications, and improve the patient's quality of life. Special attention should focus on reducing the rate of refractory GORD and complications such as Barrett's esophagus and adenocarcinoma. Knowledge and understanding of the safe and effective use of medications in the treatment of GORD, especially PPIs, prevents inappropriate use, and addresses their adverse reactions and interactions with other medications. The clinical benefits and risks of using PPIs should be evaluated for each individual case. Assessment, monitoring, audit and evaluation for disease activity, progression and effects of the therapeutic regime on a patient with GORD is important and a continuous process. For patients requiring long-term PPI therapy, the clinical effects should be reviewed regularly and treatment adjusted as required. The lower dose of a PPI that controls symptoms should always be used. Implementing person-centered care, monitoring and evaluating symptoms, outcomes, and responses to therapy plays a pivotal role in managing the illness and improving the patient's quality of life. So these are the references that were used in the production of this presentation. Thank you for watching and listening to this presentation. My name is Teresa Lowry-Lenin and I'm a member of the Carlow branch of the IPNA. Thank you.